Presentation, Professor Michael Bohm, and the title is Effect of Implanted Device-Based Impedance Monitoring with Telemedicine Alerts on Mortality and Morbidity in Heart Failure, Results from the OptiLink Heart Failure Study.
Thank you, Juan. Ladies and gentlemen, Mr. Chairman, panel, it's a pleasure for me to discuss with you the results of the OptiLink study. So the background is that in decompensated heart failure, fluid overload in the lungs occurs days, hours, and potentially weeks before signs and symptoms of heart failure developed. Therefore, OptiLink studied a telemetric approach with impedance measurement and an alert system to detect early congestion. So the study was overseen by an executive committee, an adjudication committee, and a data safety monitoring board, as it is shown here, and all authors submitted scientific support from Medtronic, and the study was a Medtronic-sponsored trial. So the primary objective of the study is whether intrathoracic impedance monitoring with an automatic wireless telemedicine approach compared to standard clinical assessment reduces cardiovascular outcome. The baseline characteristics of the study has been summarized in this document and published in the European Journal of Heart Failure. So inclusion criteria were all patients with an ICD or an ICD-D indication according to the SCAT-HEFT study or according to the guidelines in 2008 when the study was designed. To enrich the population, this heart failure population had to have a hospitalization the year before, had to be on oral diuretic treatment increases the last 30 days before, had increased BNP or NT-proBNP to make sure that indeed patients had significant heart failure and are prone to develop congestion. Exclusion criteria were all conditions which are affecting the intrathoracic impedance like renal failure and also COPD. So patients in the access arm, in the intervention arm, got a telemedicine-guided alert system with, and this is important, no audible alert for the patient. In the control arm, they got a standard clinical assessment, and they were, after implantation enrollment, randomized in a one-to-one fashion to either the intervention group and the control arm, and were followed up for 6 months, every 6 months. 18 months were followed up per patient, and the primary endpoint was a composite of all-cause mortality and cardiovascular hospitalization, and we looked at the time to first event. We have several secondary endpoints which are listed here, like all-cause mortality, the components of the primary, heart failure hospitalization, cardiovascular mortality, and all hospitalizations during follow-up. The study was powered to include, or was designed to include 1,000 patients. It was powered with an alpha of 5 for 726 patients, but we know that some patients will be dropped out, so 1,000 patients were included in the study, and these are the details of the statistical analysis. So once there is the threshold crossing of the intrathoracic impedance, the physicians had to phone the patient and arrange the necessary step, which could be healthcare advisors or an increase of diuretics, or when it turns back to normal, it is fine, or the patients had to go to the hospital and adequate action has been done. So this was a strict algorithm which is important for the trial. So this is the patients, 1,000 patients were enrolled. The final analysis was done in 505 and 496 in the two groups. And these are the results and the efficacy of the intervention. In interrogation of the device, 1,748 threshold crossings were reported. 80% of those were transferred, were occurring in 80% of the patients, 406 crossings, and about 75 of these were indeed transferred electronically to the physicians, and then the physicians took action in about 37% of these crossings, in 70-30% of these patients, and including medication changes, there was a change among these transferred crossings in about 46%. So this is a primary endpoint. The intervention group had the same rate of all-cause death or cardiovascular hospitalization. This was a composite primary endpoint. There was no significant difference between the regular care group and the CareLink group. In addition, there is no heterogeneity in between the different subgroups like age, gender, cardiovascular disease, heart failure, and others. So there is a great homogeneity among these results. The components of the primary were not changed. There was no change in all-cause mortality, and there was no significant difference between the group concerning cardiovascular hospitalization. So the secondary endpoints, as you can see here, the primary and the secondary did also not achieve statistical significance. There was a slight signal for heart failure hospitalization when the baseline the hospitalization were adjusted to the previous hospitalization. So in conclusion, OptiLink, this telemedicine care approach, was not superior to regular clinical practice to avoid total death or cardiovascular hospitalization. Telemonitoring, and this was one of the messages from this study, depends on many factors, and this is the effectiveness of successful transmission and patients and physician adherence to these signals. Thank you very much for your attention.
Great questions. Yeah, please stand up, tell us your name, speak into the microphone, and 29 seconds.
Philipp Grätzel, Springer Medizin, Germany. Could you comment on the results in the context of the InTime study, another ICD telemonitoring study that was positive a year or 1.5 years ago? Could it make sense to combine the impedance monitoring with other parameters to get to more successful results?
I don't think that it's possible to make a direct comparison. InTime has shown a borderline difference in these combined PECA scores. So it's a combination of different endpoints. And also the system was quite a little bit different. I don't think so. So this trial, and this is one of the reasons why it potentially failed, was that the threshold was not transferred in 20% of the cases. And the reason was that in 4.6% of the cases, the patients were in the hospital. Some might have been on vacation or not linked to the system, although they were intensively trained to use the system. So this is one of the reasons. And you have seen that only 50% approximately of the physician took action to the numbers. And so these can be one of the reasons why it failed. So that sets the stage to further refine the system here.
That a goodly number of your patients declined therapy because they felt well. And in my heart failure clinic, if a patient comes in fluid overloaded with JVD, even though they feel well, I still impress an intervention on the patient and they usually accept it. So do you think that affected your outcome?
Yeah, the point. Yeah, right. That's right. The problem is that the patients were contacted, and I talked to several clinicians. What the physician usually do, he asks the patients how he feels, and he said he feels, because it was a phone call usually, that he feels well. Said okay, then we stay as it is. Maybe it was an undertreatment because physicians are not trained to treat the impedance numbers rather than symptoms. So this is the identification of one of the problems here. And this is under trial conditions. In normal practice, I think it could be worse. So we need a special training and attention to these points.
Well, that was terrific, Michael. Thank you. And thank you to the